If you ask a multi-location practice owner if their group is enrolled in Medicaid, most will confidently say yes. They've gone through the process, secured their state fee-for-service credentialing, and assume their providers are covered across the board. This chart maps the total population enrolled in Medicaid and CHIP. According to the Centers for Medicare and Medicaid Services, as of January 2026, that number stood at 75.2 million people. Looking closely at how those patients receive their care reveals a crucial operational detail. Data from MacPac shows that approximately 85% of Medicaid beneficiaries do not use the standard state program. They are enrolled in managed care organizations. Each individual state can have anywhere from 5 to 12 different managed care organizations running alongside their main fee-for-service program. A practice enrolled with the state but missing 3 of the 12 MCO panels in their region generates automatic denials for a massive portion of the patients they treat. Securing your state fee-for-service enrollment handles only a fraction of the necessary credentialing. Relying on it to cover your entire patient base guarantees you are routinely treating patients you will never be reimbursed for. To see exactly how much revenue disappears into these credentialing gaps, we can examine the broader healthcare billing data. A 2026 benchmarking report by Kodiak Solutions tracked over 2,300 hospitals and 375,000 physicians. This chart graphs the total net revenue those providers lost to final claim denials and uncollected amounts. In 2024, the total was $38.6 billion. By 2025, that number surged 25%, crossing $48 billion in lost revenue. When breaking down those numbers by payer type, the Kodiak report found that Medicaid led all payer categories in both initial and final claim denial rates. Submitting a claim to a Medicaid MCO where your provider lacks an active, separate panel enrollment bypasses the standard review queue. The system simply reads "provider not credentialed" and rejects it instantly. There is no automated fix for this error. Resolving it requires a manual resubmission process, and that process only starts if your internal billing team actively catches the rejection in the first place. Medical professionals are successfully treating patients and completing complex clinical work, only to effectively donate those services for free because of missing administrative paperwork. The reason so many practices fail to capture these MCO panels is rooted in how the programs are structured. Medicaid operates as a highly fragmented network of completely separate, state-specific ecosystems. A multi-state practice must navigate entirely isolated environments. Texas uses the TMHP portal, California uses Medi-Cal, and New York uses eMed-NY. Each requires distinct login credentials, taxonomy mapping rules, and document formats. Within these portals, each state dictates its own provider revalidation cycle, typically occurring every 3 to 5 years. Missing a single deadline triggers immediate termination from the state program. This diagram illustrates the timeline penalty for missing that window. Reactivating a terminated provider requires a completely new application. That process takes up to 120 days, during which every active patient claim results in a denial. Industry research points to incomplete or inaccurate applications as the main cause of these delays. A simple name mismatch with the NPI registry or an expired license number forces the state to restart the entire review clock. What starts as a standard clerical duty quickly scales into a dense compliance labyrinth. Asking generalized in-house credentialing staff to balance this alongside commercial payer requirements practically guarantees missed deadlines and dropped panels. Recognizing the financial risk of these administrative gaps, high-performing medical groups remove Medicaid credentialing from their internal desks entirely. They utilize specialized infrastructure, like Staffingly's outsourced enrollment model. This assigns a named credentialing analyst directly to the practice. That analyst focuses exclusively on mapping and filing applications for both the state fee-for-service programs and the specific MCO panels operating in those regions. This calendar shows the underlying automation tracking those individual state deadlines. The system handles routine CAQH attestations and actively checks application statuses starting exactly 90 days before any revalidation window opens. The entire process runs on a compliant framework designed for healthcare data. It includes monthly Office of Inspector General (LEIE) sanctions checks SOC 2 Type 2 certification, and secures all state portal access behind an encrypted VPN. This level of detail is particularly critical for telehealth practices. State Medicaid enrollment is required wherever the patient is physically located, meaning a single provider often needs active credentials across multiple separate states, regardless of where they hold their primary medical license. Offloading this complexity to a dedicated analyst equipped with automated tracking transforms denial management from a reactive, costly scramble into a clear, predictable weekly dashboard. Evaluating the best path forward requires looking directly at the staffing economics of maintaining an in-house credentialing team. A credentialing coordinator earns a $45,000 base salary. Factoring in a 30 to 50% benefits load, the true in-house annual cost hits $65,000 to $95,000. Meanwhile, Staffingly's dedicated outsourced enrollment model starts at $399 per week. Over a full year, that weekly rate totals approximately $20,700. Compared to the fully loaded cost of an internal hire, a practice saves tens of thousands of dollars per position. Committing up to $95,000 in payroll for generalized staff who frequently miss deadlines and leave 85% of your Medicaid population uncredentialed simply does not hold up mathematically. Transitioning to an outsourced model is designed to be highly compressed. The go-live schedule is executed through a risk-free 14-day pilot program. Phase 1 spans days 1 through 7. The assigned analyst conducts roster mapping, performs gap analysis, and secures payer portal credentials. In Phase 2, days 8 through 14, the analyst files all missing applications and delivers a live performance dashboard tracking every active panel. Following the initial 2 weeks, the engagement shifts to a strict month-to-month structure. Practices can scale their support up or down without being locked into long-term enterprise contracts. Securing your full Medicaid revenue means identifying exactly which managed care organizations operate in your states and ensuring your providers are actively credentialed with them. To audit your current panel gaps and secure the revenue you are already earning, schedule a focused 30-minute strategy call at staffingly.com/demo.